Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Chad Mather.
Well, thank you very much, and it's a great crowd. This is usually more than I get for most talks with the residents, so I appreciate it very much. And Manny did a great job introducing me. My focus is sports medicine, and I do almost all hip arthroscopy. So the talk today will be kind of pretty much all about the non-arthroplasty treatments for hip disease and the causes for those. So I hope it'll be illuminating. And as she said, I grew up in Columbus, Ohio. There up in the upper left there. I grew up on a horse farm. My dad's a racehorse veterinarian and really a sports medicine doctor as well. I just picked a different species, so pretty much the same thing. And then I went off to Miami University where I studied economics, business, and was all the while going to go to medical school, but I could see all the earth moving underneath us even at that time, and so I chose to get some training in some other areas. Went on to Duke Medical School, and since I came down, I really never left except for the 1 year to go up to Chicago for my fellowship up at Rush University there. So I have residency here then, and then back on staff here for 2 years now. So just a little bit on hip anatomy. The hip's a deep ball and socket joint, as you see here. It's the junction of the axial and the appendicular skeleton, so the spine and then the legs come together there. So it's really important stabilizing point for the body. Of the major joints, it has the most inherent stability. Another ball and socket joint is the shoulder, and it's more like a golf ball and golf tee. So they have really opposite problems and opposite roles. So there's a lot of motion in the shoulder. The hip doesn't have as much motion, has a lot of stability. In turn, the hip is susceptible to impingement because of that stability, and less so instability, whereas the shoulder you see a lot of instability. And then we'll talk about some of the muscles here that attach into the outside of the hip right in through here that we are learning more and more about every day, and this part will probably be the most relevant to all of you in the room, and what we call kind of the rotator-cuff of the hip, which is really just beginning to be understood and very much underappreciated. So, this is some pictures of the blood vessels of the femur. This is the femoral head, and then the shaft going up here. And there's some circumflex vessels. Circumflex just stands for circular, that come to the above the bottom and top of the femoral neck. These can be injured both with chronic steroid use, trauma, other things, which leads to a problem called avascular necrosis of the hip, which you may or may not have heard of. That problem is really well known at Duke because Jim Urbanek, one of our chairman emeritus, pioneered a surgery, the first type in the world to preserve hips, had this problem, and so we still do a lot of that. I don't do that myself, but my partners do a lot of that here today. There's also some strong ligamentous structures around the hip, and one of my focuses has been to preserve these during hip arthroscopy, whereas we used to eliminate those, but they have some important roles in stabilizing the hip. Another term you'll hear a lot about at the hip is the labrum, the acetabular labrum. And again, that's this soft tissue covering that goes around the hip joint. It has a triangular structure here, and it deepens the socket, so it provides some stability, and it also provides a fluid seal that is required for normal hip function. And this is what I spend most of my days doing, is repairing this labrum and then the underlying problems that it causes, and we'll get to that in a second. So there are lots of causes of hip and groin pain, but the one thing, the takeaway here that we're really trying to work on is this problem of delayed diagnosis. We'll talk a little bit about why that is, but this is from 2006, so my colleagues at Washington University in St. Louis found that almost the average time from injury to accurate diagnosis was almost 2 years, and seeing 3.3 providers for definitive treatment. And I echo this in my practice. I see a lot of people come in who've been diagnosed with back pain or just hip strains, whatever it is, and it's a labral tear or a problem with the hip joint, and just very much underappreciated. And when it hurts for a long period of time, I always say it, it may start here, but it spreads out over the longer it hurts. So by the time 2 years goes around, your back will hurt, you have some tendinitis, some groin strains, and it's like it just spreads out from there, and it becomes hard to diagnose. But it's important as a patient, being engaged in that process, you can help solve this problem. So I won't go through all these different diagnoses, but there's you can think of it as pain up in the front of the hip, and about 75% of joint pain is felt in the front. We call your lateral hip pain, your outside hip pain, and that's really what we call now Peritrochanteric space syndrome, which includes these rotator-cuff tears of the hip, snapping IT band, and then bursitis. And then posterior hip pain, about 10% of joint pain is felt in the back of the hip, in the buttock, and that's where a lot of these patients get missed. It's felt to be from the piriformis SI joint, other things that non-hip related, and they get missed quite a bit. Now, most of those things, of course, not all posterior hip pain is joint pain, but it is one of the sources for why things get missed. And then, of course, there's other causes such as sports hernias, and then GI, abdominal things that are non-hip related. So again, is it hip pain or hip area pain, right? And so we can really think of this as, is it intra-articular hip pain, and then is it arthritic or is it not, or is it arthritis or not arthritis? So that's the first thing I do. Look at X-ray, I try to make sure. So arthritis, injections, hip replacement, best operation done in the world probably today is a hip replacement. So not a bad diagnosis of all the things you can have to have arthritis of the hip. But where I focus is in this no arthritis area, but intra-articular hip pain. And then this emerging area is this peritrochanteric hip pain, this bursitis, and especially the patients who don't get better after many treatments with that. So what does intra-articular hip pain feel like? So really most commonly what we see is this C sign. So grab the hip, say it hurts right in here, and that can be all different. It can be this window washing, wiping kind of motion where it hurts front to back, or it hurts here. And if you really think about it, it ends up with a really pointed right deep down in the hip. So that C sign. Sometimes it's just the groin pain. And you'll see that about 75% will have some form of groin pain. It hurts. The biggest thing that hurts was sitting. So that's what makes it unique from a lot of other problems. Is it hurts to sit. That's what also makes it really hard to deal with in your daily life. It's very disruptive because you can't sit down. I have people coming all the time who can't drive to work. Can't sit at work, and so it's one of those problems that it really affects our emerging service sector. A lot of the desktop jobs are dramatically affected by intra-articular hip pain because of the pain with sitting. And at the same time, as we'll talk about in a second, flex twisting activities are what aggravate it. So getting in and out of a car, putting on socks and shoes, and of course anything that really flexes that hip, going uphill, start up. Those are kind of your big signs of intra-articular hip pain. But like I just talked about, it can be very atypical. It can be primarily buttock pain. Got a patient I just saw yesterday. It's mostly up in his back, but it's definitely was his hip confirmed by an injection. So we have to constantly be on the lookout for that. And obviously, I'm the last line of defense here for the hip. So if I don't find it, then a lot of people will not. So I really try to catch all those. And a lot of times you'll see some mechanical symptoms, catching and locking, and associated with this. Like I said, I wish it was all wrapped up in a pretty little box, a lot like the shoulder or the knee, but it's really atypical and it can be really hard to diagnose. So a little bit about who gets hip pain and why they get hip pain. So like I was talking about, it's a real stable joint, so it's susceptible to this impingement problem. So you can have abnormal anatomy that's just going to abut itself no matter what you do, or you can put a lot of stress on it. You can put your hip in non-physiologic range of motion, like these two athletes right here, or be a laborer who's really asking a lot of their body. And so it's really, we can think of it as either as a combination both of use and then the anatomy that you have underlying. And then if you think about extra-articular hip pain, so that's kind of your intra-articular side. And what about your extra-articular side? And that's, again, that peritrochanteric space stuff we talk about. That's mostly felt as lateral hip pain. It hurts with stairs, hurts with startups, especially getting from a seated to a standing position. It really hurts to lie on the side. And most people are very disrupted by this because it affects their sleep. And anything that affects how you sleep is really, really aggravating. You can get this problem after a fall, which is more concerning for a tendon tear, and then you can get some snapping of that IT band. I'm always on the lookout for gait abnormalities. So if you're coming in with a walker or cane, that's concerning to me, that there's a lot of weakness and potentially a disrupted tendon that needs to be fixed. And so you'll see in this patient, this person here cannot contract their this actually muscle here. This muscle. So here's the gluteus medius muscle. There's a drawing of it. Comes down the side here, contracts and then stabilizes the pelvis and really abducts the leg and moves it out to the side here. And when that muscle doesn't work, that side lengthens and this side drops. So what you see is when people walk or throw I'll step off the camera for a second, but walk like this because you don't have the strength to hold yourself up. So you have to throw your weight over to the side to walk in order to compensate for that weak muscle there. So that's something we're always on the lookout for, because it can be a sign of a little bit worse problem, and it will lead to worse problems if untreated, because you can imagine that there's a lot of strain on your back and your knees and the rest of your body, and that's a lot of times what's so hard to get over. Where it hurts is like that. I was just talking about that gait and that Trendelenburg sign, and then you'll be weak lifting the leg off the table, as well as pain out in this area. So this is that bursa. If you hear about trochanteric bursitis, this is what we're talking about. But what we're learning more and more are that a lot of these bursitis situations that don't get better are because this tendon has torn. It's like a rotator cuff tear. I'll show you that here. So we kind of got the two intra and extra-articular and what they look like, how they feel. We'll go into a little bit of causes of hip pain. So the most common thing that I treat is a labral tear. Now, oftentimes they are very common, period. And probably if we did MRI on everyone in this room, definitely over 90% of you would have probably a labral tear on their MRI. It's part of aging. We don't fully understand why that rate is so high, but it is also clearly a source of pain in certain folks. So it rarely occurs in isolation. There's usually something else going on, like this impingement or a dysplasia or something like that. The primary cause of arthritis and the primary cause of labral tears is a problem called Femoro-Acetabular Impingement. So this is one of the big takeaways of the day. And this, this is really common in all age groups. It starts in the teenage years, and I see it all up through 50s and 60s really pretty readily. It occurs when the femoral neck here, this femoral neck right here and here, when that abuts the acetabular rim, so the cup here, at the extremes of motion, which is usually that flexion and internal rotation of the hip. And it can be like I said, it can be due to activity, but also due to these what we call abnormal morphology, or there's the shape of the hip. So you can see this side is nice and round; it's got a nice offset, and this side flat. It doesn't really not looking like that's going to fit into a round socket, and that's exactly what happens. A PINCER type is when the socket's too deep, and then the neck hits the rim and squishes the labrum and tears it. And again, it is the primary cause by far and away the primary cause of arthritis. We still don't know how it's caused, but we think it occurs at the time of skeletal maturity. It's probably related to sports. So it's something we're trying to figure out a little bit more. So again, we have the CAM type, where that CAM just refers to aspherosity, otherwise round structure. So you have round structure. Now you have aspherosity, so area where it's not round. And then here's your PINCER type, where it's it's too deep and it catches that. I don't want that to come up here. And that's just an example of what a CAM looks like in an anatomic specimen. I don't know if I have control of that up here. Okay. There we go. Okay, so what does that look like? What happens with that CAM impingement is it peels back the cartilage. This is the acetabulum here, the cup. Here's your labrum, and it will result in these big cartilage tears in the extreme sense. And what I'm showing you here is this is the labrum here, and this is the acetabulum here in an arthroscopic view, and you get again tearing of this cartilage in through here. What it looks like on an X-ray, we term it the pistol grip deformity. So again, it has that flattening up here, and it looks a lot like a gun. So That's what we call it. And then this is really what's happening. So there's that bump, and then as it rotates into the hip, like I said, there's no place for it to go, so it pushes itself in anyway, and eventually leads to a tear here at the junction of the labrum and the cartilage, and there you get that delamination of the cartilage there, and then eventually that extends over time and becomes arthritis. All right, and then for pincer impingement, you've got where you can see where really it's a crush mechanism where it crushes that labrum right here, and will lead to some severe redness and swelling and deformation of the labrum there. Again, this is that femur here. Here's your acetabulum. There's your labrum. And then here's like a pit where this has been contacting the rim over and over, and it's actually dug itself a trough in the neck of the femur. What's that look like on the X-ray? This is a three-dimensional CT scan of the pelvis, and you can see here there's this extra bump of bone out here, there and there. That's where you're getting that pinch. And the mechanism for this one is more, like I said, of that crush phenomenon, where it crushes the labrum and the cartilage as well. So that's what I do pretty much day in, day out, is fix all those things. So, arthritis is obviously where those end up, right? So, again, everything's looking good. 18-year-old here. He's got is cam impingement over here. You can't really see completely on the X-ray, but you can kind of see where it's flat in this area. So everything's happy and good. Playing basketball, playing football, whatever it may be. We get to about 35 here. The joint space starting to narrow. So, and then we end up here even in the 40s. You can get this problem where it's really severe end-stage arthritis. So, again, that's kind of how that progression works there. But that's kind of your causes of those intra-articular hip pain, the majority of them. We'll talk a little bit about those rotator cuff tears of the hip. This is one right here. This is a muscle here, the hip. There's the tendon, and you can see that hole in the tendon right there. And then here's after we've repaired that with some suture anchors and things. What we call that now is Peritrochanteric space syndrome. It's again this area out here. We call it the peritrochanteric space. So here's the greater trochanter of the femur. Here's your pelvis and everything, and then the skin will be out here, and you have that band of muscle and tendon out here, and it pinches against that bursa. And that bursa is designed to allow that to move over that bony prominence, but it sometimes gets inflamed and then becomes a nuisance, becomes a problem. Here's again that gluteus medius muscle tendon attaches up on the pelvis, a big broad fan-shaped insertion there, and then it extends here. Inserts down as a thinner tendon down on the tip of the trochanter. Here's an MRI, patient I saw the other day, and you can see that it kind of matches up there, and you can see that tendon is not attached anymore where it's supposed to be. So this, you can see a lot of this white fluid is what we see with a lot of inflammation from pain, and this person was very, very limited, very unhappy, unable to sleep, a lot of pain, limp. And all likely they should do very, very well having that fixed surgically. Again, a large majority of these are just simple bursitis, just some inflammation, nothing big. But when they don't get better, you can be thinking about whether there's a tendon tear. When there's a bad limp, you're thinking about a tendon tear there. It actually occurs in as much as 25% of the population at some point, so it's extraordinarily common. So again, most of them aren't ending up here, but we're missing a lot of those that are out in the community. We need to start catching more of those. Much more common in women, and you see associated with low back pain again because you have the limp there, that gait disturbance that causes the back to then hurt over time. That's a good video here too. Yeah, that was going to show you how it snaps. So there's two different types of hip snapping. There's this internal snapping hip and this external. So the internal is from the iliopsoas tendon. This is this tendon that flexes, allows you to flex your hip. Comes along the spine over the front of the hip and inserts really just right there on the proximal femur, right into there, and it will rub and snap over the hip joint basically, and it sounds like a really clunky, loud thunk sound. We say this is the type of snapping you can hear, and this is the type you can see. So this external snapping hip is when that band of, you can feel it on yourself, that kind of tight band of tissue out there, fascia, tendon, will get too tight and it'll snap over that trochanter, and then we say this is the kind you can see. And this is what a lot of people say, my hip's dislocating. Well, hips don't really usually dislocate very rarely in kids, but not really in adults does that happen unless you have a severe car accident. So this is what it seems like. It's very abrupt, and it's really snapping back and forth. And the video, you'll be able to see it real well. And then that internal snapping hip, or what we call psoas tendinitis, is a real common cause of hip pain. It seems like it could be joint pain because it's over the front of the hip, but it often has that clicking. It's often painless, and it's reproduced from coming from that flexed position out to an extended position. But fortunately, it responds really well to non-operative treatment. I can't think of that I've ever even operated on one of these, but they are common. They just get better with therapy and injection. So. And but sometimes they can pinch the labrum, and that's what you see here. Maybe this one will work. No. And this is the labrum here, and you can see how red that is. We call that the lipstick sign. And the psoas tendon runs over here, and it's just squeezing and pinching that labrum there. So, other causes of hip problems are hamstring tendon issues. So, this would be the severe type, really common with water skiing. See a couple of these every summer, and it's again from that the legs extended, and then the boat pulls you and pulls the tendon right off the bone there, and that's exactly what you see there. A lot of pain, bruising, weakness up really around the buttock. Most hamstring strains are in the muscle, and they don't need really much treatment. But these you'd want to get these repaired. If you know anybody water skiing and now they're stumbling around and they've got a swollen buttock, then you want them to be you want them to go see somebody, because these do a lot better when they're fixed, as you might imagine, right away. It's a pretty big muscle. You don't want to walk around with that thing torn off there. So. The other side of that are the chronic ones, and there's probably, again, some of these tendinopathies and partial tears of the hamstring tendons that we're still trying to understand their role in pain and the hip pain, and again, that's going to be more your really point tendon buttock pain right up where you sit down. The difference between that and hip joint pain is you can really touch that, you can really push it and it'll hurt, versus hip joint pain, which you can't really touch. Other causes of hip pain, as we talked about, you've got kidney stones, ovarian cysts, pregnancy. There's other neurologic problems, back pain, other things around there. We try to work through those as well. Again, when we're evaluating this, the first thing you need is some X-rays, and again, this is what we call this is that deep pincer impingement. You can see how deep that socket is compared to this one. And it's even pinching. You see these are the cysts on the neck from this hitting here so much. This is the opposite problem. This is called dysplasia. So you can see there's no socket. These cysts are from arthritis occurring, and this is also a common cause of arthritis. You'll see this problem more when you have a lot of motion. So really a stiff hip, probably going to be arthritis. A lot of range of motion in the hip, but it's painful. Maybe more like dysplasia. Injections are a wonderful treatment for this problem and for diagnosis. So I rely on these heavily because of that atypical nature of the presentation, and they're really accurate for determining hip pain. So if you have an injection and it feels better for a few hours, that's the best test we have. It's better than MRI. It's better than anything that tells us that the hip joint is the problem, and it's really predictive of good results with surgery. MRIs do have a role. This is your femur again, your acetabulum. Normal, nice triangular shaped normal labrum here attached to the acetabulum. And there's the tear cutting through that one there where it's not attached anymore. Here's a cyst that's compressing. This is the femoral nerve and the femoral artery and vein, and the nerves in there as well. And this cyst there's fluid. This fluid has snuck out through that tear and not compressing that nerve as well, so that can get that bad. But like I said when we started, they're really common, and they're usually not a source of a problem. Actually, we almost all have them at some point. So we'll do a little bit about available treatments for these problems. So definitely spend some time on the non-operative treatment, because that's really where you can help us help you on this, and this is really to engage in this. You can be a lot more successful with it. So that you really think about it in 3 ways. So you want to treat the inflammation, the soreness, and the pain that you have, but what's going to make you better in the long term is to address those functional deficits. You can't have repeated injections. You really don't want to be on medications forever. So you really need to use these in the short term to be able to use the rehab to address these functional problems that can help you then in the long term. And then while you're doing this, you need to reduce those aggravating factors. If it hurts a lot to sit, you need to cut out as much sitting as you can, or deep sitting, for that period of time, or it won't really be successful. So for physical therapy, what you really want to focus on are addressing the neuromuscular imbalances. So a lot of people have weak hips, and that's one of the things I'll show you again. I guess I'll be off the camera for this, but when your hips are weak, the knee tends to go in when you squat down or you jump, land, the knee goes in because these hips are weak, and that's right into that impingement position. That's what puts that bone in contact with itself. So if you can learn to get away from that position, a lot of times you can that successfully treats the problem. There's also this foam rolling is excruciatingly painful if anybody's done it. So, but it works really well for some of that IT band stuff, and that's what they're doing here is stretching that there. So there's a lot of great therapists, and again the key is really to see a good therapist, but also then to do a lot of it on your own. And other than the foam rolling, physical therapy as a rule should not hurt you. It can be uncomfortable. But it should not really be painful, unless again this is basically a form of deep tissue massage, which is supposed to hurt for it to be effective. So what's the success rate of non-operative treatment? With this young hip, this pre-arthritic hip disease, labral tears, impingement, etc. Those less than 50% success rate with non-operative treatment. So we have about 45. That's what 45% is what the published results are. I think if you really are good about 1, 2, 3, I think you can get that up over 60% or around 60%. If you just go straight to physical therapy, it often will make it worse. So if you're going to therapy for hip pain and it hurts, then that's not. I mean, there's a reason for that. That's actually not uncommon, and that's because again you have so much inflammation there. You can't do anything without treating that first. So I really do a lot of injections early on, but I do no more than 1 injection typically, unless there's arthritis. Arthritis is okay to have multiple ones, as long as you've gotten a few months of relief with those. Because we do know that repeated injections, the medications do probably cause some damage to the cartilage over time. And we want to avoid, especially in the young athletes and who are beating up their hips. We don't want to do. We want to preserve those hips, and one injection only really for those. And then you want to be careful about prolonged pain and dysfunction. So we know that the longer you go, the worse you do when you do get it fixed. We know that that video of tearing the cartilage, that's over millions of cycles of that, and if you keep going with millions more, it's just going to get worse. So I tell people every day, pain is a protective sensation. So it's telling you there's something wrong. If you can fix that, then you should really get that fixed. You shouldn't go on and be in pain. And then, as I was talking about, it also leads to back pain. It leads to pain out on the side, groin pain. It really leads to a lot of other. And then after a while, that back pain becomes real. It results in disc degeneration and other problems that can't always just be fixed by fixing the functional deficits. We get into that peritrochanteric space problem. You had about 90% success rate, probably maybe even higher than that. More injections are acceptable here because there's no cartilage out there, so it's a little bit safer. But I saw somebody the other day had over 20 injections, big tendon tear, and probably that contributed over time. So my maximum here really is about is about 3 of these, and then we really need to start thinking about why is this not working. Now, if it's lasting you a year, that's probably okay. If it's lasting a couple months and you can repeat inject, probably not that doesn't necessarily mean you need surgery, but it does mean you probably ought to think about why that's not working and what else to do about it. But again, physical therapy by far is the hallmark of treatment here. Things to be concerned about: if you have pain or weakness immediately following a fall or an injury, you really again have that gait after an injury, then you may have had a tear of that tendon. And if you have really substantial limp or weakness, to me, I'm a little bit more concerned about that. So who's likely to succeed with this? So with non-operative treatment, if you really have a lot of muscle weakness, that's something you can work on. So that's good. Mild impingement deformities do well. Tendinitis, as we said. And then this less than 2 millimeters of joint space on that x-ray usually means your arthritis is getting worse, and hip arthroscopy at least is not a good option. And then with surgery, generally athletes who are requiring a lot of end range of motion, or workers who are doing a lot of that flexed rotating, probably not going to do well with non-operative treatment, just because they're going to continue to be in that impingement position. So how do you know if non-operative treatment doesn't work? We've got a lot of good options for you and what to do about it. And hip arthroscopy procedures are skyrocketing, and the techniques have improved incredibly. It's the toughest procedure to do, toughest arthroscopy procedure to do, which is one of the reasons that's what all I do. And this should be done by people who do a lot of them, because it is very technically challenging, but it is incredibly successful when done well. And so we've seen a huge increase in those, over 100% increase over the last few years. This is where most of my videos were, but just real briefly on what hip arthroscopy looks like. It's 2 to 3 small incisions out here. This is the outside of the hip here, and then you'll see a camera and then some instruments that go through. We use traction to pull the hip out to safely get into the hip to address the things we need to address. Had some good videos there for you. But this is just with that labral repair, we're trying to restore the suction seal. Here's the femoral head. Here's the here's the labrum and the acetabulum up here, and I've got there's the sutures holding that labrum back to the rim, and we've got a nice seal maintained there. You can see that redness where the pincer effect was happening in this person, but nice seal back there. That's what we're going for. And then on the reshaping side, we take a high-speed burr. And about 12,000 RPMs, and then we're going to take a bump like this, a flat area, that pistol grip deformity, and we're gonna make it better again. And so we do with that burr, we reshape that so that it not having that impingement anymore. And the outcomes from this are really quite good. And when again there's no arthritis or no dysplasia or any of those contraindications to the surgery. Let's get to that there. That's what it looks like here when you're done there, where you've reshaped that bone and made it nice and round again. Yeah, these are good. This is a good one here. This is a gluteus medius repair. Unfortunately, you won't see that, but this is a big tear right here. Here was actually the muscle, and that really nice repair. I was hoping to show that to you, but this is another example of that. The results on these are short term because we haven't done them for a long time, but they're excellent. They really do result in improvement in strength and pain. And again, something to think about if you've got a bad limp or if it's persistent pain after physical therapy and injections. You've really given a good effort. Done 1, 2, 3, couple injections, still not getting where you need to be. And you'll think about these tears as potentially being a source of the problem. And things are really growing rapidly, not only in the number of procedures but in the amount of research done. So you can see this is a chart of the numbers of publications around Femoro-Acetabular Impingement and hip arthroscopy, and it's an exciting area to be in right now. So in summary, hip pain is common and it's commonly misdiagnosed. So be on the lookout for that. Again, it's most commonly felt as a C sign. It can be purely buttock, but can be purely groin. And then arthritis, again, counts for most of the surgery performed on the hip in the United States, but pre- and non-arthritic conditions can be treated effectively and better all the time. Non-operative treatment, about a 50% success rate with the joint approximately, and about 90+% for that extra-articular stuff. Surgery has excellent results when done in the right situation, on the right person, by the right person on the right person. And again, that lateral hip pain, if you're seeing that gait disturbance or multiple injections, and again, you've done 1, 2, 3 on the non-operative treatment, think about getting an MRI and seeing myself or another sports medicine specialist. And then that snapping hip we talked about almost always responds to non-operative treatment. Really rarely do we ever have to operate on that. Well, thank you very much. And questions or anything?